So today is a day that I've got an important announcement about the way that I run my practice, because I'm going to make some changes, and it's because I have often thought that you see people who, with their private practice, I actually work with other doctors who to help them grow their private practice, and it's quite common to see doctors who grow their private practice and get busier, and actually that can detract from the service that they give. It's something that I quite often see, and it's something that I've always been keen to try and avoid, because I have tried to make service one of the sort of main aspects of the practice that I got, and I've never really wanted to be one of these guys that are busy all the time and doing massive theatre lists and massive clinics where you're in and out, and you sort of go into one room and see a patient, then go into the other room and see the next patient and all that. So I know that suits some surgeons. That's how they want to work, and that's fine. But it's never really been the way I wanted to work. And so I was at the BARPS meeting recently, the plastic surgery meeting in London, and we I was talking to some colleagues who have got busy private practices, and they've got big waiting lists. They've got like 6-month waiting lists, really busy, doing a lot of operating every week. And for me, I'm like that. And basically, they don't want to employ other surgeons. I mean, the obvious thing is to get other surgeons on board, and they don't want to get other surgeons on board. And so that's fine if that's the way they want to run it. But I say to them, it's not a very good service. If you've got to wait 6 months, that's not a great service, and it's only going to get worse if you get busier. And I don't really want to be in a situation where I get busier and I give a worse service. So I've made a decision to drastically reduce the surgery that I do, because I want to really focus on giving a really good service to the patients that I do operate on. But also, we're doing a lot of work at the clinic with the see and treat. We're doing, I think that's a really big asset of the clinic, that we've got our own operating theatre. We don't share it with anyone else. It's just ours, and so we can have the ability to see someone in the clinic and then perform the treatment there. And then that's for minor procedures, moles, cysts, a lot of tattoo removals, lumps and bumps. So we're really pushing that and working on the see and treat service. And I've got other surgeons that work there, so other consultants who will see patients. But for me, I'm drastically reducing it. So from now on, I'm going to be seeing 3 people, or at least operating on three patients a quarter. Is what I've decided. Is the sort of and it's going to be for those patients, I'm going to really focus on the service, and it will be a very personal service, and really it will be something that no one's doing. It'll be a level of service that no one really is doing. And as I say, I see some of my colleagues who are actually, the busier they are, giving a worse service, and I'm like, that's not my model. I actually want to give a better service to people. So it's hard to do that at volume. Hard to do that at scale if you're scaling. And one of the problems I was getting at was basically operating too. I was doing too much, trying to run the clinic, trying to build the practice. Working with my colleagues, as well as doing the surgery. It's just too much, and I didn't want to get to that situation where you're spreading yourself too thin. So I'm going to limit how many people I personally treat. So I'm going to be just treating a very small number of patients, but I will still very much be involved with the other consultants, and we work together at the clinic. We get on very well. We've got Azam Faroa, Sam George, and Kostas Apostolou, and more who want to join. So we are growing, and those other consultants, I will support them. But personally, it's going to be drastically different, the amount of number of patients I treat. Now, that's not going to affect anyone that I've already treated. All my normal patients are going to be, I'm going to look after them just as I would have before. So there's no effect on anyone who have already treated. So it's only just for new patients moving forward. So, the majority of patients at the clinic will be operated on by my colleagues. And I'm just going to really focus down on giving a really personal service to those few people that I do treat every year. So just, as I say, 3 people a quarter. So we'll decide at the beginning of the quarter who I'll treat, and then obviously next quarter we'll look at it. But I don't really want to have this sort of busier, more and more surgery. It's not for me. I'm not a high volume, never have been really a high volume operator. I don't want to be a high volume operator, and it's quality, not quantity, with the way I want my practice to go, and that's what I'm doing. And I think it's what we can deliver when we just focus on, say, 3 people a quarter. We can really do world-class service, very personal service. Be myself, be Vicky, the clinic nurse, very personal service for those patients. And we can deliver something that no one in the world is doing. Literally no one in the world is doing. I think the surgeons in the world that are known for doing procedures are all high volume. There is no one who is focusing on the service. So I do really believe that this will be a world-class level of service that no one will be able to approach at the moment. Yeah, it's exciting, and it will, and I think it'll be really good, and I think I'm really looking forward to just having that sort of focus on those small number of patients, so that we can develop proper time, proper really make them feel looked after. So yeah, we've got in place the service that we're going to offer, and the packages we're going to offer. So yeah, it'll be and it'll also give me an opportunity to do more in terms of the building of the clinic and supporting the other surgeons. As I say, the other surgeons will still be there, and so yeah, that's the announcement. I mean, it's big for me. I don't know if as I say, if you're a current patient, it won't have any effect on you, but it's how we're going to go moving forward from here. I keep on getting this thing coming up saying Bird wants to join. Now, usually when that happens, it's a mistake. But if it's not a mistake, I will accept the join. I think I'm going to come into your Facebook won't be able to see this, but I think I'm going to come into your living room when I say accept. So I've accepted it. If you want to talk to me directly. Hi, Bird. Did you want to talk to me directly?
No, I just wanted to join the
oh, so you didn't want to go on like a one-to-one thing like this?
No.
Oh, right. How do you turn? I don't know how to turn it off now. Is there anything you can do? We're on like a split screen now. Can you do something? I'm not. That's your TV. What are you watching? You're not double screening. You're double screening. What are you playing at? Right. You know what the problem with the live stuff is, that you can't kind of practice it. That's your TV again. You right? Shall I? Do you think I should be able to do something? I'll tell you what.
I think you've got to do your end.
Here we go. Turn off requests to go live. Turn off questions. Yeah. No. Add. Remove. Oh, here we go. I'm going to remove you. All right then. Okay. Okay, you're moving now. Remove. Confirm. You're still there, aren't you? Are you still there?
I'm still here. Do you want me to?
No, it's okay. If you remove, they won't be able to rejoin. Oh.
Oh.
No, I don't want to remove you like that. No. You know what? I think I've just removed someone else.
Oh.
I think I've just.
Oops.
Come on, surely you can do something. Can't you do something your end? Is there no buttons? What about your? Look at your buttons. Are you pressing your buttons?
I'm pressing my buttons. I don't want to leave though.
What's that? Oh, that's going to turn my screen. Oh, look, that's my window.
Oh,
I'll just turn my screen round. Right. Oh, just turn my camera off.
Right,
Oh, that's ending. Oh God. Oh. Right. Oh well, if you're on Facebook, I think I just I know I just ended the live video. Okay, I'm back again. Right. Right. If anyone has any experience of using Instagram Live and they know how to have someone join the live and then take them off the live, please let me know, because I don't know how to do that. But anyway, thanks for joining, Bird. It was lovely to see you. And sorry that I just pressed the wrong button and left it myself. Anyway, back now. So yeah, so that was the I can't hear anything. Are you on mute? Oh crikey. So that's Facebook. Now that just tells me that people on Facebook, it just shows you how many people don't actually listen, don't have the sound on. That Nicole's telling me that now at quarter-past. So right, Nicole, I am not on mute, Nicole. No, I don't want to cast the blame, but Nicole, is your sound on? Respectfully, I have had problems with my microphone in the past, so I have full disclosure that I have history of having mute issues. But I had a big camera on a big boom here, which I thought was a very professional setup. I got rid of it, so I've just got this one now on the speaker. So I think I've just got one like play test. That's not going to help, is it? Because that's me. So I don't think I am on mute. Is anyone else on Facebook? This is the problem with when they can't hear you, because if you can't say, "Can you hear me?" So Instagram can hear me, but Facebook can't. Shall I write the back of this receipt? What is that? I might need that. Right, I've got some paper here, but can you hear me? On Facebook, can you hear me? Not Instagram, Facebook. Can you hear me, Facebook? Oh, that's backwards. Is that backwards for you? God, am I writing? God, here. I mean, here looks really. It doesn't look so bad when I look like that. Can you hear me, Facebook? Can anyone else hear? I don't think it's my device, as I've left and rejoined, but still no sound. Can anyone else hear on Facebook? That says here. Here. Can you hear? Anyone? No. Oh heck. Is that? But I can't blame Bird, because Bird was on Instagram. So let's buttons, and let's see if something happens. Please let me know if something happens. My what I should be doing. Yola Karimo is in the house. Amy Louise, Jonathan will have a lesson tomorrow. Yes, we'll have a lesson. Well, the problem is we have to do a lesson in the live world. Danielle, what you got? You got any hearings? Hello. So I could go and come back on Facebook, couldn't I? Just did it on Instagram. Anything now? Hello. 21212. I believe I'm having this problem now. I thought I got rid of that problem when I oh, that's good, isn't it? I can flip mirror cap. Oh, so that means I can. Well, that's the right way around there. Yeah. I can't hear either. Jill can't hear. Jeez. Let's get the technical team. First, oh God, what's going on? First of all, it all went wrong when Bird had joined, and I couldn't get rid of her. Now, no one can hear me. Facebook. What can we do? 21212. 21212. Oh God. I need to upgrade my account. Okay. Facebook people, can you hello? Me neither. Oh God. I can type. I could have typed, couldn't I? Could have typed in the chat. Didn't think. What about anyone got Instagram? It's okay on there. Now, I don't get in trouble from Facebook by encouraging people to go to a competitor. It's not a competitor, is it? It's the same company. Does that go? So I'm trying. Is that high risk? Oh, I've got 2 internets here. I can change it. If I get a no, I'm going to change my internet. But I'm going to start asking questions otherwise we're all night because I've moved to Instagram and can hear. Oh, well done. Good. Okay. I'm not sure what's going on in Facebook. If I still get a no there, I'm going to do the internet change thing. I've got little things to say. I've got a question. No, I haven't got a question. Oh heck. Right. So let's do the Q&A because that's after all what we're all here for. Have I got any questions on Facebook? Right. Let's go. I'm going to start. Here we go. What is the scarring like immediately? Comment on a post. I've got a comment. Oh, good. Okay, I've got a question. What is the scarring like immediately after having tattoo excision? Well, interestingly, reboot Facebook. Right. Yeah. The problem is, Lowry, with rebooting it is it's kind of yeah. I could. I mean, it's linked to a certain like time. Yeah. Because it's like not on right. Okay, I'm not gonna. I'm gonna do it. well, I'll do the internet thing first, and then I'm going to change internet. Don't know what that does. I'm going to change the right. Has that helped? I've changed the internet. Any good? If not, I'm going to go back to no. With the internet changes, will my upcoming surgery be affected? Oh God, don't blame me if it goes wrong. Yeah, I'm gonna change it. I'm gonna book the surgeries. No effect at all. It's just patients who are having surgery. So it will be a new inquiry coming tomorrow. You know, that's how it will be if they want to. You know, we'll be obviously the see and treat will be going normally, and the other consultants will be going normally. But I'm going to be just doing a very small number of patients personally. But as I say, if you've booked and all that sort of stuff, it's all completely normal. So, oh look, that's Facebook. Facebook sound is working, isn't it? I've got Facebook open here, and listen. It is working. Facebook sound's working, isn't it? Everyone's gone. There's one person on Facebook, and guess who that is? Got 2 thumbs and speaks French, yeah? Moi. Right, okay. Anyway. Right, well, there you go. It's working now. They're all gone. Anyway, Instagram's still alive and well. Thank you, Instagram, for putting up with me trying to make Facebook work. So, what does the scarring look after having a tattoo excision? So, interestingly, actually, immediately after having a tattoo excision, the scarring doesn't actually look too bad. So you come back after a week, so you have a dressing on, so you won't see the scarring for the first week, and then after the first week you will have the dressing removed, and the scar probably won't look too bad. It will look fresh, but it probably won't look too bad. And then what normally happens is after the first few weeks, so I normally catch a person. So a week you normally have the dressing with Vicky. I normally catch up with you about 6 weeks, and at 6 weeks the scar often looks worse. So the scar basically often looks worse before it looks better. It looks quite red and feels quite firm. So immediately it doesn't look too bad. It kind of looks like a line. But then at 6 weeks it often looks more red, more firm, more kind of thicker. And then we get you massaging it, and then over the coming months it sort of softens and settles. So it kind of gets worse and then it gets better. So that's kind of what to be prepared for. So it is important to be prepared for that, because if you kind of think, oh, it's too bad, and then at 6 weeks you think, oh, it looks terrible, don't worry, it often does that. Got a question on here from Nicole Danielle. I hope you're still about, because you were on Facebook and couldn't hear anything. But I'm hoping that the sound's working now, but I don't know. What Q1? We've got 2 Qs, Q1 and Q2. Q1, what does an exercise program look like post tummy tuck? Q2, how aggressive is the lipo? For example, how do you determine how much fat to remove? Okay, so let's do Q1. What does the exercise program look like post tummy tuck? So there's a couple of things in terms of exercising post tummy tuck. One thing is in terms of the general health of yourself, and the second thing is in terms of the specific of regarding the exercise regime for your abdomen. So more importantly, really, is yourself and your general kind of health, really. And so the things in relating to that is you got to move. So you've got to get up and get moving. In the old days, people used to be in bed rest for weeks and stuff like that. Don't do that anymore. Up and moving day one. Day one, you're up and moving, and you need to keep moving. Keep your legs moving, keep your ankles moving, keep your bum moving. We don't want you getting clots in your legs and DVT, fly off into your lungs. So keep moving. I'm not talking about going crazy for a crazy long walk. I'm just talking about pottering around your house. And when you're not pottering around your house, when you're sitting on the sofa watching telly, keeping your legs moving, your ankles moving, just keeping everything circulating. Same when you're on the way home from the surgery. Keep everything moving. So keep everything moving. The other thing is we don't want you getting chest infection. So keep taking deep breaths right to the bottom of your lungs. Inhale and then cough if you need to. If you need to cough, that's fine. Don't worry about your tummy. So in general terms, you need to keep moving and keep taking deep breaths, and that's the most important, I would say. In terms of the specifics of the abdomen, would be secondary to that. So I really do stress the need to keep moving and keep coughing and taking deep breaths, because you can get quite ill if you don't keep moving and keep taking deep breaths. In terms of the specifics for your abdomen, that would be more like just a lot of it your body will tell you. So a lot of it will be guided by your body. But in general terms, I normally say to people, take it easy for the first couple of weeks. And again, it doesn't matter what I say, you will not feel like doing much for the first couple of weeks. You will feel a bit uncomfortable for the first couple of weeks. And then after a couple of weeks, and you'll be bent over, you'll be hunched over because your abdomen will feel tight. So it will be a bit uncomfortable for the first couple of weeks. And then you will start to walk a bit straighter, just as you feel up to it. In terms of exercises, I normally say start with lower body, exercise bike, stepper, what's it called, cross trainer thing, and then just sort of build up. And as you build up, then you can start doing the core and exercising your kind of upper body. But it's normally at least a month, probably 6 weeks before you start doing that. And then it's just starting to do it. You don't want to go too crazy on it. If you go too crazy on it, then it can be a bit uncomfortable and it can swell. Those are the things that will happen. It'll be uncomfortable and it'll swell. So yeah, that's the sort of normal regime for a tummy tuck. Now, Shifnal Nails is asking to be in the video. I'm not doing that again, Shifnal Nails. If you want to, I will say yes, and we'll do a split screen and you'll be here. But I did it a minute ago and it all went Pete Tong afterwards because I couldn't stop it. So if you do want to, then just say you want to and I will accept it. But I don't know how to end it once it starts is the problem. So I'm going to put in Facebook, I think sound is okay now. Am I right? So thank you for that. Nicole, what's been going on in Instagram? I've got to be honest, I feel like I've not really kept up with what's going on here. I think it was my question that went missing on here. Was it your question? With the imminent, was there a question I'm missing? With the image change, will I no? Well, oh God, don't blame me if it goes wrong. Well, it's gone pretty wrong so far. What the imminent changes? What I miss? 3 patients a quarter. Corinne, I'm going to be reducing the amount of work that patients that I treat, and I'm going to be really focusing and doubling down on the service that I give to those patients. With myself and Vicky and the team, we're just going to have a different kind of model into how we treat patients. With myself, the other surgeons will be working as normal, so the clinic will be operating, but my workload is going to be significantly reduced. Have I missed the big announcement? Yes, Harry, you have. What if we're hoping to be under your care, operated by? Yes, if you're hoping to be under my care and operated by me, it will be completely normal. There'll be no different to current patients. So if you're a current patient of mine, or if you're due to have surgery with me, there's absolutely no difference. That will go as normal. But moving forward from here on in, for patients inquiring and having wanting to have surgery, and again the other guy, there's 3 other surgeons at the clinic, and there's going to be more coming on, so we'll all be working together, and that will still happen, and I will still be supporting them. But in terms of my own personal workload, I am going to be taking on 3 patients per quarter only, and I'm going to be giving a much more personal service to those patients in order that I can continue with my ethos. And my goal has always been, the whole reason I got the clinic was to give a better service to patients. And one of the problems that you get when you get busier is you give a worse service. And I see it in other surgeons, I see it in other doctors. They get very busy and they kind of wear it like a badge of honor that they've got a 6-month waiting list, and they're they're in and out, and they're not seeing their patients post-op, and they're really quick with the follow-ups and stuff. And I'm like, that's not who I want to be. I want to actually give more time to patients, because I think that'll give a better service. So to that end, I'm going to actually reduce the number of patients I see, and I think it will really be able to give a world-class service, which is what I've always been about. Larry, what you got? What does it need to be for breast reduction and tummy tuck? What does what need to be? BMI? Is that the question? What does it need to be? Well, if it's BMI, 30 is the normal number. I don't insist on 30, but that's kind of a normal number people talk about. I'm assuming that's what we mean by what is it? Oh, big changes ahead. Hope that means you can take more time for yourself. Yeah. Corinne, thank you. Hi, I want to have breast enlargement early next year. What is the main pros and cons between teardrop and round shape, please? Now, at Shift Nails, if you want to be in the live video, I will let you be in the live video, and we can talk about that. God knows how we can end that live video. No one knows, but if you want to, but the main pros and cons between teardrop and round. So a lot of people will say teardrop's more natural than round, which is not strictly true, although it is kind of sort of true. The teardrop implant is slightly less full in the upper pole than a round implant. So a teardrop implant has got the point of maximal projection in the lower part of the implant, as opposed to a round implant, which has got the point of maximum projection in the central part of the implant. So it's a slightly more dome shaped. The teardrop implant has got that lower pole. So a normal natural breast has got kind of like a teardrop shape. So that's kind of why people say, oh, teardrop natural, round look fake. But it's not the end of the story, because if you've actually got some breast tissue, particularly if you've got breast tissue sitting in the lower part of the breast naturally, then you can get a natural result with a round implant, because you get different profiles of round implant. You get low, moderate, high, and extra high. So for me, I think teardrop implants really come in when you've got nothing. When you've got nothing, so if you're doing a breast reconstruction, for instance, after a cancer, you pretty much always use teardrop. So if you've got no breast tissue, then a teardrop, yes, will give a more natural result than a round implant. But if you have got some breast tissue, particularly if that breast tissue is sitting a little bit low in your chest, then you can get a natural result with a round implant. So you kind of need it to be assessed, basically. So it's mainly about the look. In terms of pros and cons, the big potential con with a teardrop is it can rotate, which a round one can't, or at least it can rotate, but it doesn't matter if a round one rotates. But if a teardrop rotates, it looks odd. So that's the kind of main con difference between the two. You can only get teardrop implants in implants that have texture to them. There's a lot of smooth implants around now, and what they're called smooth opaque implants, and they don't make them in a teardrop shape because they don't adhere. So that's another thing to consider. But basically, the bottom line is you need to be assessed. So we need to look at your breast, look at the sort of volume you're looking for, look at the sort of look you're looking for. So a lot of times people say they want a natural result, but they look at some of the results and they think, hold on a minute, that looks a bit droopy, and like, well, that's natural. So if you want a bit of a fuller result, then maybe a round implant, you might be more towards a round implant. But if you do want a softer look in the upper pole, particularly if you haven't got much breast tissue, I think a teardrop implant might be the way to go. But it kind of needs a discussion. But yeah, it's one of the things we need to focus on if we are so it's hard to say without kind of examining you, seeing you, talking to you, what do you want, sort of thing, what sort of look do you want, because pretty much everybody coming to the clinic says they want to look natural. But we use teardrops, we use round, we use low, moderate, high, and extra high profile implants, and you can get different degrees of natural with all of them, and it's it's not a easy thing to tell over the airwaves. Shift Nails Beauty, you keep saying review request. If you do want to be in the video, then just say. But when I did it a minute ago, it didn't go well at all, quite frankly. So I'm a little bit anxious about that. I keep on getting things here. I've got a question. Let's have no questions. Okay. So I'm going to rise above it unless you put in the chat, can I talk to you directly? And I am happy to talk to you live in your living room if that's what you would like. So what we've got here, I would like to have a mole removed that is on my vermilion border. If the worst happens and my lip looks a lot smaller or pulls to the side, would lip liner and makeup make it less noticeable and possibly filler at a later date? If the one side of the lip was considerably smaller, will the top lip definitely look pulled and deformed or not noticeable makeup? I thought we had this well, it wasn't last week or last time. But anyway, I know exactly who this question is from because I think it's someone I've been chatting to on the WhatsApp. And this is a difficult one because it's quite a large mole on the top lip. And yes, it does involve the vermilion border, so that's quite a big deal. The vermilion border is the border between the pink of the lip and the kind of skin coloured of the skin of the top lip. So you can't really see mine because I've got a beard, but you know that border between the lip and the normal skin is a big deal. And so when a lesion crosses that, you have to be very careful at lining that up again, because if you don't line it up properly and you get a bit of a step, it's kind of obvious. It really draws your eye to it. So that's something you've got to be really careful. So when we do this sort of surgery, we often use magnification to get that lip vermilion really lined up properly. So that's one thing. The vermilion needs to be lined up. But also, this is quite a significant mole, and it's on one side of the lip. So if we're going to remove it, a significant part of the lip has got to be removed. And this is very difficult because I know this patient is very anxious, and I can tell from the WhatsApp and what have you. And I know she wants me to say it's going to be fine and it's going to look normal. But you cannot remove a large part of the lip without a consequence. So that part of the lip will be smaller. And no, you can't add filler. Filler will make the lip that's there fuller, but it doesn't give you lip back. So it won't bring the lip back. You will have some of the part of the lip removed. And one of the problems is because the mole's on one side of the lip, the central part of the lip, the philtrum, might get pulled across a bit. It will probably get pulled across a lot to start with, and then it will be better in a few months, but it might always be a bit pulled, that side of the lip. And lip liner and makeup, I'm not sure if it will help. You know, I wouldn't suggest removing it if I didn't think it would be something that we could do. But whether we should do it or not is really completely up to you, the patient, because it is a significant mole and it will require removing a significant part of the lip, and that will have consequences, and it's really hard. And I've already shown a photo of someone who's had quite a large part of their lip removed to give you an idea, but that's a different person. You kind of want to know what you're going to look like, and I really can't tell you what you're going to look like. I can just tell you it can be done. I'm happy to do it, and it's something that is a doable thing, but I can't tell you it's going to look 100% normal, or you can use filler afterwards, or you can use makeup afterwards. Obviously you can use makeup to cover the scar because there'll be a scar there, so you can use makeup to cover the scar, but you can't use makeup to cover this fact that, you know, a good half or more, I think, of that half of the lip, so like you know, easily a quarter, maybe a third of the lip is going to be removed. So a significant part of the lip is going to be removed, and it can, you know, your lip will cope. You can remove a large part of the lip and be able to close it directly, but it may look pulled and there will be a scar, and so it's really difficult. And yes, you can use makeup to cover the scar, but it won't help cover the pulled bit. Shift Nails Beauty, you keep on pressing the, I don't know what's going on. I'm assuming you don't want it because you said thanks for the explanation, it really helps, but you haven't said I want to be in the live video, so I'm gonna continue ignoring that. I don't know if you other people on Instagram Live know that someone's requesting to go live. Do you know that? Maybe you don't know that, so maybe I just don't talk about it and just move on. So yes, Harry, that was the big announcement. Have we done that? How would you describe the amount of a breast reduction if not using bra sizing? Oh heck. Sorry, I have no idea. Good. Okay, that's good. You can't see it. Okay, well, I'll just ignore it. Look, shift nails. You've done it again. Anyway, that's fine. I'm gonna rise above it. And again. Okay. Um, how would you? Yeah, that's a really good question. How would you describe the amount of a breast reduction if you're not using bra sizing? Um, well, that you when I talk to people, I ask them what size they want to be to get an idea. I'll be honest with you, bra sizing is the only thing we've got to talk about the size of the breasts. So we do I do talk to you in terms of sizing. So, but I can't guarantee what the size will be. So if you are like a J and you say you want to be a C or a D or even a double D, I'll be like, I'm not sure if you're going to get from a J to a double D. Um, I think it might be a bit bigger. E, maybe. I don't know. I mean, it's quite vague sizes, especially above double D. I think it all gets a bit vague because they kind of do double D, but then they just do E and then the F and But so I will say, look, I think if you're a F and you want to be a double D, yeah, fine. EF and you want to be D double D, that sounds kind of doable. But that's how we talk. And when I'm doing the surgery, I try and make it I try and stress, obviously the size is important, but the size isn't everything. You have to get the shape right. You have to keep the nipple alive on a pedicle or like a stalk of tissue, and that will carry with it a certain amount of volume. So you are limited to how small you can make it. So if you're very big, you can't make it very small unless you do a free nipple graft. So a free nipple graft is a slightly different operation where you actually take the nipple off. So that's a slightly different. Not many people are candidates for free nipple graft. So that's a slightly different situation in a free nipple graft, but in a kind of normal, if you like, or a standard breast reduction where you keep the nipple attached, that will limit how much smaller you can make it. Because often when you do it, you kind of completely empty out the breast, and all you got left is the pedicle, pretty much. And so then you might think, oh crikey, that's still quite big. But you might have taken off, 800 grams or a kilo or more, but it still looks quite big. But you daren't take any more away because you've got your blood supply and your nerve supply going to the nipple. So sometimes you have to say, look, you know what? I don't think it's going to be a C. I don't even think it's going to be a D. I don't know what it's going to be, but it's probably going to be a lot smaller. I mean, that's one thing I do say. It's going to be a lot smaller. You never sort of wake up and think, oh, have I had something done or not? It's always significantly smaller, but the specific cup size we can't guarantee. So it's just trying to get you on the same page as to realizing where we are in terms of doing the surgery and how we kind of assess how small we can make it, and just trying to make you aware that if you have got your heart set on maybe a C cup, for instance, and you're a HJ or something like that, then that might not be achievable. So maybe either don't have surgery or maybe find someone who maybe can achieve that for you, or kind of accept it. So it's better to kind of accept it prior to surgery rather than thinking you're going to be a C and then waking up and you're bigger than a C and being annoyed about that, because we'll do our best to make it as small as possible, because most people do want it as small as possible. But I do think shape's really important. So when you do, sometimes you see people when it's over resected, it's a bit flat, hasn't got much projection. You've got to be a bit careful in terms of, making sure that the shape still looks good, because the shape can be an issue if you do go too far on it. What you got, Corin? Personal experience after breast reduction with JJ, best to go for resizing after everything settles. Hard to be precise on size. You heard it there from real life testimony there from Corin. Thanks, Corin. Shift Nails Beauty, it keeps coming up, this request to go live. I did say I wasn't going to say it again, mention it, but so I'm not, so that's it. So carry on. If in your breast reduction, which technique do you use and why? So yeah, I mean, sometimes you find some surgeons, I think, probably will have a technique that they use kind of regularly. I do use different techniques in different situations. So the way you talk about technique of breast reduction, I guess the two ways to talk about it is one in terms of the pedicle, the stalk that goes to the nipple. So you can do different pedicles, And the other way of talking about it is the scarring that you get, the scarring that you see on the outside. So obviously the pedicle that you use, you can't see from the outside. It's something the surgeon does. And I use different pedicles in different situations. So a very small reduction, just a balancing reduction maybe, so more of a lift. I use a superior pedicle, so I take the volume out of the lower pole, the lower part of the breast, take the heaviness out of the lower part of the breast to give a more long-lasting result, because you don't want the heaviness in the lower part of the breast pulling the breast down. So you want the volume of the breast to be in the upper part. So you empty out the lower part and then tighten the skin. Now a superior pedicle kind of moves up, like straight up, if that makes sense. So it's based, just go straight up. So for a slightly bigger reduction, it will kind of concertina that pedicle, concertina up. So you can't really do a big pedicle with a significant distance for the nipple to move on a superior pedicle. So for a slightly bigger reduction, and I would say probably the most common one that I do is a superomedial pedicle. So superomedial pedicle comes at a slight angle, and the nipple kind of rotates up. So I don't know how much this is interesting to you guys, to be honest with you. Now I'm talking about it, but anyway, I've been asked the question, so I'll carry on. So that's a superomedial pedicle. So that's for, I would say, the most of the breast reductions I do are a superomedial pedicle. So for a bigger breast reduction, so somewhere, and the way we measure how big a breast reduction is usually by the nipple transposition. So from the position of the sternal notch to the nipple where it is now to the position where we're going to put it afterwards. And the longer the transposition, the longer the pedicle. If it's going to be a long pedicle, a safer pedicle to use, in my experience, is an inferior pedicle. So for a long pedicle, there's a risk that superomedial pedicle might kink, the blood supply might not be quite so good, and you worry you might have more risk of problems with the nipple with a superomedial. So for a bigger breast reduction, I'll use an inferior pedicle. Now the downside of an inferior pedicle is you do have volume in the lower part of the breast, and it can make the breast look a bit boxy, that pedicle there, but it's a safer pedicle for a bigger breast reduction. So maybe the shape's not quite as good as with a superomedial or a superior pedicle, but it is a safer one for a big transposition of the nipple. And then finally, there is the free nipple graft for someone who's got a very long transposition, 10, 15 centimeter transposition. You would think about a free nipple graft where you literally take the nipple off, you do the reduction, and then you put the nipple back on again as a graft. So I do all of those. And those are the ones I do. There's other pedicles people use, lateral pedicle, bilateral pedicle, or a horizontal bipedicle, vertical bipedicle. So there's different types of pedicles, but those are the ones I use commonly. A superior pedicle for a smaller reduction, superomedial pedicle for the majority of breast reductions, and for the big ones I use an inferior pedicle. And then finally I have free nipple graft for extremely large ones. Now in terms of the scarring either goes round the areola, which is called a circumareola, also known as a Benelli. It can go round the areola and straight down, which is called a circumvertical, or it's also called a lollipop. Or it can go round the nipple straight down and in the fold, which is called an anchor scar or inverted T-shaped scar. And most of my reductions end up being some degree of anchor or inverted T. I never say never, but pretty much never do a circumareola, do a Benelli. I can't make it look good. I don't like the scarring. It's all wrinkled and puckered, and so only for a sort of maybe some kind of balancing or tuberous breast deformity, or maybe in some circumstances I might do a circumareola. But any significant breast reduction, if you're going to do a breast reduction and reduce the size of the breast, that also involves reducing the skin envelope. And I think which is where the lift comes in, and I think you're going to get a much better lift with at least a circumvertical or the lollipop. And the lollipops I usually will do for a lift with implants, where the implant's taking up some of the slack skin, so you don't have to take up a huge amount of skin. So for most breast reductions, would have that horizontal scar as well as the scar around the nipple and straight down. I try and make the scar as short as I can. So that's, I think, the main thing. I think if you're going to use a T, try and make it as short as you can. So I will often do a short T. So you don't want to have it coming, so you certainly don't want it visible. You don't want it coming too far medially or laterally. So I'll try and make it as short as I can. But the more skin you've got to remove, the longer that scar is. So if someone has got a significant droop to their breast, and again has a significant transposition of the nipple, then that scar might have to be longer in order to take out that horizontal excess of skin. So if you don't put any horizontal scarring at all, and you just do a circumvertical or a lollipop, you're not taking any skin in an up-down direction. So you end up with folds, and you hope that those folds and those ridges will settle. And sometimes patients, doctors who do that technique quite a lot, will almost call it a second stage to revise that and take those folds out and convert to a horizontal scar. So personally, I just go straight. Often will do the horizontal scar if there is excess skin in an up-down direction. So the majority is an inverted T or an anchor. But as I say, I try and make the horizontal scar as short as possible. The reason people don't want to do a horizontal scar is obviously less scarring is better, but also the horizontal scar is often the worst scar. It's often quite red, quite obvious, but at the same time it's quite well hidden because the breast kind of falls onto it. So fortunately, the scar around the nipple and straight down do fade really well. And personally, in my hands, I can get a better shape with that T-shape or inverted T-shaped scar. But there are people out there who do a lot of horizontal scars, single vertical scar or lollipop lifts, and they get good results. So, different strokes for different folks. Good question, that. What we got? Trian. Hi, I've heard about breast implant illness and it does worry me. However, I still really want them done. So is there any way to avoid it, please? No, there is not. Sorry, Tran. We've got a little accent on the A. Nice. How'd you get that? You got a special keyboard. There isn't, Tran, I'm afraid. I have to say, it is not as common as you might think. If you go Googling it, and if you go look at Facebook and all these places, you will probably find quite a lot of people who talk about breast implant illness. I think I'm right in saying I've never had a patient of my own who's had it. I have treated patients with it. Now, I'm not saying there's something I do to make it not happen, because I don't think there's any surgeon can say they do something to make it not happen, because we don't really know what causes it. But what I hope that does show is that it's not as common as you might think, because I do a lot of implants. So it's not that common, but it does definitely seem to be out there. And I have treated patients with it, so it seems to be a thing. And it's just one of those things to put into the mix if you're thinking of having implants. There are bad things that can happen with surgery, with any surgery, and certainly with breast implants, there are some bad things that can happen. You get infected, you might have to have it removed. You can get a very rare cancer, ALCL, associated with implants. They can go hard, you might have to have them changed, and breast implant illness. There's all these things to put into the mix. There are risks with doing surgery, but you've got to balance those risks against the benefits, because there's big benefits. There's a lot of people who are very happy with their implants and have got no problems at all. So, you just got to balance it. And it depends on how much of a problem it is for you. And if you think, well, they would quite like to have it done, but I'm worried about breast implant illness and I'm not sure if I want to risk it. Well, don't risk it. Don't have it. But if you think, actually, you know what, I think I would feel a lot better, then the benefits might outweigh the risks. So it's a very personal thing, to be honest with you, as to whether surgery is right for you. It's very personal, and it's really something that no one can decide for you. We can just tell you what we can do and try and put the risks in context, so you don't kind of think, oh my God, this is going to happen, it's terrible. There are risks of everything in life. Getting in the car and going down the road, there's risks. Going to the shops, there's risks. Going on holiday, there's risks. Going skiing, there's risks. There's risks with everything in life, and it's about the benefit versus the risk. So if the benefit's great and the risk is small, you might do it. If the benefit's not that much and the risk is pretty bad, you might not do it. So only you know what the benefit is. And I've got to say, you're probably doing riskier things in your life if you go on holiday or if you drive a car. But nevertheless, you have to put it into perspective. So I'm sorry, Tran, there is nothing you can do to avoid it. It's with all types of implants. There's no specific type of implant that's associated with. People talk about saline implants, but even saline implants have got a silicone shell, and the people who have it think it's the silicone that have made them feel ill. There's no medical reason to say that silicone can make you feel ill in this way. So we haven't got any reason we don't know why it happens. But as I say, it does seem to be a thing, so it is something to be aware of. So I don't know if that's helped you, Tran. I don't know if I've allayed your fears or made it worse, but try and basically kind of you know, I need to try and get, I always say you need to try and get like above 50% with your decision. You know, I don't want to sway you one way or the other, but in your heart, hopefully you can get maybe above 50%. And once you've got above 50%, either way, if it might be not having surgery, which is fine, or actually, you know, you want surgery, then try not to dwell on the negatives. Try to, if you're not having surgery, try not to dwell on how good it would have been if you'd had surgery. And if you are going to have surgery, try not to dwell on, oh my God, I might get implant illness or all sorts of problems. You know, try and be positive about whatever decision you make. But when you're in the decision-making phase, yeah, you need to kind of try and balance it up. It is difficult. Do you do both saline and silicone? Yeah, to be honest with you, saline we don't really do in this country. I mean, you can get them, but saline implants do have potential problems. They're kind of like bags of water. So rippling's more of an issue. They can deflate. And as I say, they've still got a silicone shell. So there's still silicone there. So saline implants, we don't really use in this country, to be honest with you. They still use them in America, but in the UK, we don't really tend to use saline implants. And in terms of getting the result, getting a cosmetic enhancement of your breast, a silicone implant will give you a better cosmetic result than a saline implant. So yeah, silicone is the way to go if you're going to go for it. But I understand your concern, Tran, and yeah, it's about balancing the risk, really. Thanks for the question. Thanks for joining in. I'm glad you can hear me. I'm assuming you can hear me on Facebook now. Then good, right? Okay. Is breast reduction used? Here we go. Do we offer back fillers? Back fillers. What's a back filler? Filler in your back? No. I've never heard of back fillers. What are back fillers? No, we don't offer back fillers. Well, we don't. What am I saying? We don't offer fillers. We don't do any non-surgical work, so I don't even offer lip fillers and things like that. So certainly not back fillers. I don't know if that's a typo. I don't know what back filler is. Oh, what have we got here? We've got stuff. So, how long should you have considerable contracture before replacement surgery? Pure nails and beauty. What can I say? There's no should about it, and it's a very personal decision. And you don't have to have surgery if you've got capsular contracture. Capsular contracture is it does happen, and it's kind of like a natural thing, really. I mean, it's scar tissue that forms around the implant, makes the implant go hard, and you know, and it's kind of inevitable over a period of time, and it really depends on you. So there's different grades of capsular contracture. The first grade, you can't see it, you can't feel it, therefore everybody's got grade 1 capsular contracture, everyone with a breast implant. Grade 2 is where you can feel it and you can't see it. Grade 3 is when you can start to see it, and grade 4 is when it gets uncomfortable. So it's normally grade 3, 4 where you would think about having surgery. So when you can just feel it but it looks fine, most people would not consider having surgery. But when you can start to see it, you know, the breast looks a bit full and a bit high up here, and particularly when it gets uncomfortable, that's normally when the stage when people think about having something done about it. But it's a personal decision. Pure nails and beauty, it's, you know, we're not going to tell you need to have it done. It's personal to you as to when you choose to have it done, because when you do have it done, if you're going to have particularly if you're going to have new implants put in, if you're not going to have new implants put in, then you can have it whenever you want. But if you are going to have new implants put in, that next set of implants will start to go hard. So, you know, if you can delay it, it's probably going to be better, because you're going to start the clock ticking on the next set of implants later. So it's probably better to delay it as long as you can. Although obviously, if you're on discomfort and what have you, don't want to sort of like make you be uncomfortable. But you know, on general terms, the longer you leave it, the better, because you're going to start the clock ticking on the next set. MR5H enhanced. Is it common when having a breast augmentation with a lift, borderline needing a lift, that you could have the lift done via the nipple rather than having a full anchor scar? Thank you. Yes. So that's where you use less scarring when you're doing an implant and a lift, and certainly the less, because the implant will be doing some of the work of the lift, if you like. It'll be taking up some of the slack skin, so you'll need less skin removed. And so that's where personally I would tend to use the circumvertical. So those are the situations I use the circumvertical, also known as a lollipop. So you may well not need that T-junction, which is good because you can get healing problems. And as I say, the horizontal scar might not looks so good. But yeah, those are the situations where you might not need it. But again, if there's folds, if the shape doesn't look right, I will convert to a short T. But you're absolutely right that the situation where you're borderline for a lift, you'll need less scarring. Could you just have an areola one? Possibly, but you'd have to be really borderline. I would kind of think, is it worth doing a lift at all? Because I don't like just the areola scar. I don't think it gives a very good lift personally. Okay, Trian's back at me. What you got, Trian? Tran, sorry, it looks like Trian when I see it from here. It's Tran, isn't it? Sorry. Tran, I have lumpy breasts and a few lumps have been removed in the past. Am I still okay to have you? Yes, absolutely. No problem at all. Absolutely no problem at all. When you put implants in there behind the breast, so you can still feel lumps, you can still be examined, you can still have lumps removed. There's no problem at all, Tran. Even patients with breast implants can go on to have implants for balancing surgery. If they've had a mastectomy on one side, we might put an implant on the other side if you want to be reconstructed to a bigger size. So yeah, no problem if you had lumps in the past, that's fine. And as I say, moving on in the future, you can still find lumps and examine breasts normally with implants in. Loco-lopulus, when you perform a tummy tucks, with all the subcutaneous fat be removed and lipo to give a tight, firm tummy, or could you still potentially be left with loose skin? Do you know what, Loco-lopulus, are you? This is the next question here. Is this you? How aggressive is the liposuction with the tummy tuck? For example, how do you determine how much fat's removed? Slightly different question than that. But anyway, we'll take them together if you don't mind. So when you perform a tummy tuck, I mean, $1 million question, isn't it? Am I going to be happy with my flat stomach, or could I still have loose skin and be unhappy? Now, obviously, we're going to try and make it absolutely perfect and tight as a drum and beautiful and flat, and you're going to be delighted. But welcome to my world. When you're doing the surgery, you close the wound as tight as you can, and sometimes you have hairy moments. You think, oh my crikey, I've taken away too much, it's really tight. Because if you take away too much, there's a risk the wound can open up, and that is not fun at all. There's a risk that wound can dehisce, can open up. And you have to break the operating table. You have to bring the operating table into this sort of position like this and close it up tight. And you're thinking, oh crikey, I hope I haven't taken away too much. So we try not to take away too much because we don't want the wound to open up, and it can be not good. So we're always trying to not take away too much. The flip side of that is if we want it to heal beautifully, heal so that there's no problems with the healing, no risk of dehiscence. You might say, oh goodness me, I don't want it opening up. Oh goodness me, no. Okay, well let's ease off on the excision then, and let's make it heal nicely and like it closed really nicely. It's very easy to close. Well, then you're going to be potentially left with loose skin. So there's a balance between being left with loose skin and it opening up and being a disaster. So we're trying to make it perfect, but sometimes you get the wrong side of perfect. Sometimes you get a little bit to open up, sometimes you get a little bit of loose skin. So is there a risk you'll potentially be left with loose skin? Yes. Do we hope that you won't be? Yes. So so the subcutaneous fat is removed from the piece that we remove, but there's subcutaneous fat in the skin that's left behind. So you still have subcutaneous fat on your body. If you didn't have subcutaneous fat on your body, you'd have skin stuck to your muscles. It would look odd. It would look like a skin graft. It would look like, people have had burns and stuff. It looks odd. So you have to have fat underneath the skin so that it moves and it's got give. So it's not all removed. So coming back to this question, how aggressive is liposuction with a tummy tuck? How do you determine how much fat to remove? You could extend that out to how aggressive is liposuction full stop. How do you know how much fat to remove when you're doing liposuction? It doesn't matter. Forget tummy tuck, any part of the body. And the thing about liposuction is we're trying to bring you back into a normal contour. And I always say to people, when you're doing liposuction, you're trying to make it perfect. A bit like the loose and wound dehiscence and thing. You're trying to make it absolutely perfect. But there is a risk. There's a risk it's not perfect. There's a risk you can do too much, and there's a risk you can do too little. So if you do too much, you get a dent. If you do too little, you have a residual bump and you think you haven't done anything. Out of the two, it's a lot easier to correct it if you do too little. To be honest with you, you can just do a bit more. If you do too much, and you create contour irregularities, dents, they're much more difficult to fix. So, how do you determine how much fat to remove? I haven't got an answer to that. You just do the surgery and you try and make it look good, and you try and make it perfect. And I'm sure every single surgeon in the world who is doing liposuction is trying to make it look perfect. But sometimes it's not perfect. Sometimes they overdo it. Sometimes they underdo it. Um, we've all been there if we've done liposuction, and there's no way to say this is how you make it perfect, because otherwise, if there was that, we'd all just do it perfect and no one would ever have too much or too little. And unfortunately, people do have too much and too little. It's why I always say to people that you've got to choose your surgeon. People worry about implants and this and that, all these aspects of what when they're having the surgery, but they don't think too much about the surgeon they choose. You've got to choose your surgeon, and there's no answer to how much how much fat you remove when you do liposuction. You remove enough, but you hope you don't remove too much. That sounds a bit crass, maybe, but what can I say? It's the world we're in, and it's the life of a plastic surgeon. Look at that. They used to call me Wiggy. Yeah, this guy used to be called Wiggy. Stress of the job, man. Stress of the job. Always trying to make it perfect. What we got? Pure Nails and Beauty. You did my surgery. You did my breast augmentation 2012 and did an amazing job. Thank you. Treble thumbs up. Well, that's good, Pure Nails Beauty. What were you asking Pure Nails Beauty earlier? How long? Oh, capsule contracture. Capsule contracture now. Anyway, 2012, done well, Pure Nails Beauty. Well, Pure Nails Beauty, you know where I am. Call me up. I said earlier about limiting that surgery I'm doing, but for patients of mine, then I'll be very happy to see you. Always happy to see my own patients. Pure Nails Beauty. So love to see you at the clinic. Give us a call. No charge. Always welcome. If you want to chat about stuff, or we can just do a chat phone videos and stuff like that if you want to chat about things. But thank you for putting that in a public forum. It's very nice that you are happy. Thank you for that. Loco Loopy Loose. Oh, I see. Do you offer free revisions if loose skin remains? Yes. Loco Loopy Loose. So you normally need to wait at least 3 months, ideally a year, really. Now the revision thing is 6 months, so we offer, but you kind of get an idea at 6 months. So, and what we'll do, if it's looking a bit not so sure at 6 months, we'll put a revision request in at 6 months, but we might wait for a year to do it, because often things will tighten up and will improve over time. But yes, for sure, if it doesn't look right, Loco Loopy Loose, and loose skin is one of the risks of tummy tucks, that there is loose skin remaining, especially if you have a problem, if you've had something to stretch the skin afterwards, like hematoma or a seroma or something, a prolonged seroma or something, and it's stretched the skin a bit, there is a risk that you could have a bit of loose skin. So yeah, and but yeah, we would revise it for sure. No problem. Thank you, Loco Loopy Loose. But yeah, obviously try and avoid revisions. But if you do need revisions, it's bad enough that you have to have a revision. We wouldn't charge you for the revision if if it doesn't look right. I've been told having breast implants in about 10 to 15 years time, it might need to be removed and replaced when it gets hardened. Should I bear that in mind and start saving for that procedure in 10 years time if I have my first implants now? Tran, that would be a very sensible thing to do, because I can tell you now it's more expensive. So if you do need to have them removed in 10 years time, then it is a more expensive operation than the first operation. So yes, you should consider that now, because it doesn't have to be removed at 10 years. But it might go hard in 10 years, and you might need to have it removed. And as I say, a capsulectomy and change of implants is a more expensive operation than the putting implants in the first place. So for sure, that's a very sensible thing to do, to consider, and to perhaps start putting money aside for it, because it's quite expensive doing a capsulectomy and a change of implants. It takes about 3 hours, as opposed to an implant operation that takes about an hour. So it is quite a bit more of a big deal doing a capsulectomy. So for sure you should think about that. Very good point, Tran. Very good point. You're obviously thinking about it, which is good. So yeah, if you know where we are, if you need us, call me. I'm still going to be there, and I'm still going to be fighting to build the brand, and looking forward to as I say, just reducing the amount of patients I operate on and giving a much more personal service to those patients. So yeah, I will be back next time, hopefully not have quite as many technical issues as I had this time, but who knows, probably will. And if you have any questions, call me, message me, Instagram me, Facebook me, YouTube me, and I'll do them next week. Loco Loopy Lose, you are very welcome. And yeah, for now it's time to put the old feet up and to watch a bit of telly. See you next time. End the stream. Tran, Tran's come back. I want them done in February 2024. Should I get booked in now? Yes, Tran. February 2024. Yeah, I mean, you can't. Yeah, actually, it's not far. Actually, February 2024, is it? I mean, what I normally say, because sometimes people want it in like 6 months in time and stuff like that, or 12 months time. You can have a consultation anytime. I mean, personally, for us, we don't charge for follow-up consultations. In fact, we always encourage people to come back for a second consultation. So you know, there's no harm in having a consultation now. But as I say, February 2024 is not that far, and certainly we are booking around that time now. So yeah, I think it wouldn't be a bad idea to, if you are thinking of having surgery, to start the ball rolling, Tran, with that. So yeah, I think you should start the ball rolling on that one, because yeah, that's going to creep up on us, I tell you. Okay, Tran, you've been a ledge. I think you get the most comments prize, so well done to you for that. And thank you. Another comment there. Thank you very much. No, thank you. And yeah, you know where we are if you need us. If you want, call us or message us on Facebook or something. And yeah, we'll be happy to help you out. Right. So without further ado, I've stopped the stream on Instagram already. I will stop the Facebook/YouTube stream, and I'll see you next week. I might see you soon, Tran. Take it easy.